I'm Julie Kirkland, and in this video I am going to be demonstrating and discussing different points of CPR and different styles of CPR that can be performed on our veterinary patients. This is one of our canine patients today named Cody, who's going to be helping us out. So with all CPR, the reason we are performing it is when we come across a patient that is apneic or non-responsive. So when we do come across that, the first thing we're going to do is a brief 10-second or less evaluation of the patient to check our ABCs, our airway, our breathing, and our circulation. So by examining the oral cavity to see if there's any obstructions, we're going to pull that tongue to the side and make sure that there's no obstructions, foreign bodies in their vomitus that could prevent proper circulation or ventilation. We're going to check our chest cavity, looking for rising and falling to see if we're breathing, if we have any ventilation on our own, and we're also going to check for a heartbeat. If all three of those things are not met, sometimes you will only notice one or two, maybe not the heartbeat or the pulse, because those can be less accurate at that time. We will immediately try to wake our patient. Cody, Justin. And if no answer, we're going to immediately call for an assistant to come help if we have an individual that can do that, and begin our compressions. So if you are by yourself and you come across a patient that is apneic, again, the ABCs, checking my airway, I don't see any breathing, and I'm not feeling a pulse, I'm immediately going to start compressions by holding my hand right over this small dog's heart by measuring elbow 1/3 up the chest. I can find where that heart is. I'm going to place the heel of my hand palm right over that heart area. Take my upper hand and generally lock it into place with the fingers so that the hands aren't sliding around. With elbows locked, shoulders directly over patient, not leaning on patient, bending at the waist, you will be doing compressions. If you're by yourself, you'll be doing 30 compressions followed by 2 mouth-to-snout breaths. By doing a mouth-to-snout breath, we're closing the mouth entirely so that there's no air escaping, breathing into the nares of our patient, 2 breaths. So 1 and 2, with our mouths as close to the snout as possible, of course. When we're doing that, we're making sure the neck, spine, and thoracic area is elongated as possible so that that airflow can continually go straight through to the best effect. And then resume compressions if at that time there are resume compressions for a full 2-minute cycle of BLS, basic life support, before evaluating for a pulse or a cardiac rhythm. So again, you're by yourself, it's 30 compressions. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 2 mouth-to-snouts. And then resume compressions, 30 compressions again, followed by 2 mouth-to-snout breaths for a repeat of 2-minute total. After that, again, checking for pulses, heartbeats, and ventilation or breathing at that point. Repeat this cycle until help is received or otherwise the patient is declared at that time. If we have multiple people, there are other versions that we can add on to that, including going into ALS, which involves incorporating drug therapy for our patients. One of the most important rules of circulation is to never lean on the patient's body, and therefore we're allowing the body and the thoracic cavity to fully recoil. So when we're doing our compressions, again, we're going 1/3 to 1/2 of the body's cavity's depth down, and then we're completely coming back up with the body recoil. We're not lifting off the chest, causing extra exertion for the compressor, because that compressor will already be working hard with their compressions as is. We're going to keep our hands completely on the body at all times, do our compression, and release to the natural positioning of that thoracic cavity. So for the original compressions, we performed a cardiac compression, which was the elbow was bent 1/3 up the base of the body from sternum to dorsal. And then we measured that 1/3 up. That is where our location of our heart is, directly where that elbow hits. Yeah. So by pressing directly over the heart, we encourage the circulation via the heart. The other versions that we could do would be for a larger barrel-chested dog. That version originally that we did is great for the smaller dogs and the keel-chested dogs as well, and patients. For the larger dogs that we're working with, like our Rottweilers with the larger barrel chest, we're going to use the thoracic pump theory, which involves us pumping our hands directly over the widest portion of the thoracic cavity, which is going to be cranial or caudal to the heart. So if this is our heart on our larger patient and our chest is about this big, we're going to go to the outside caudally or cranially and use that as our pumping. And from there, from that compression, we're creating the negative pressure, which is going to allow for that circulation through in and out of that thoracic cavity. If it is a feline patient or a smaller pediatric patient or a geriatric smaller animal, we can also use the cardiac pump theory, but instead we will be using our hand with a motion of only our hand as the compressor, as opposed to both hands pushing from one side solely of the body. So if this is our heart on a small kitty patient, we would be doing our compressions right here. Same quantity, same theory of amount of pressure being used, 1/3 to 1/2 of the chest capacity, to make sure that we're having the proper circulation and exertion for what the patient needs to produce the proper amount of ETCO2 readings, which we will do in our ALS cycle. One of the most important rules of circulation is to never lean on the patient's body, and therefore we're allowing the body and the thoracic cavity to fully recoil. So when we're doing our compressions, again, we're going 1/3 to 1/2 of the body's cavity's depth down, and then we're completely coming back up with the body recoil. We're not lifting off the chest, causing extra exertion for the compressor, because that compressor will already be working hard with their compressions as is. We're going to keep our hands completely on the body at all times, do our compression, and release to the natural positioning of that thoracic cavity. So for this session of CPR, we are going to be demonstrating a full 2-minute cycle of BLS. I'm going to have a teammate for this one, and we're going to start as if we were coming across our patient for the first time who is apneic. Okay, so Cody, checking for our airway. No breaths, no heart rate that I can feel. I'm going to start compressions for a full 2-minute cycle, starting now, and calling for a teammate. Patrick, help! 1, 2, 3, 4, 5. Just found our patient unresponsive. Can you place the intubation? Yep. Thank you. 6, 7, 20.
Tube is in.
Tube is in. 30, 32, 35, 6, 7, 8, 9, 40, 1, 2, 3, 4, 5, 6, 7, 9, 50, 1, 2, 3, 4, 5, 6, 7, 9, 60, 1, 2, 64, 65, 68, 72, 73, 74, 75, 76, 7, 8, 9, 100, 2, 3, 4, 6, 7, 8, 9, 10. Setting up ECGs, thank you. Setting up ETCO2. Thank you. 60, 62, 64, 65, 66, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, thanks. 1, 92, 93, 94, 95, 96, 97, 99, 100. Checking for pulses. No sign. Looks like we're asystole. Do you agree?
I agree.
Okay, I'm going to switch you to start compressions and I'll take over. And then we'll continue this for a 2-minute cycle, introducing our IV catheter and then any medications if needed. Thank you.